Good evening, everyone. I am Zeenat Chauhan, Training and Education Leader, Healthcare Ultrasound. I welcome you all to today's webinar, An Approach to Diagnosis of Common Congenital Heart Defects in Fetus, powered by Wallison series. The fetal heart is a significant focus in pregnancy management as the detection, diagnosis, and the management of congenital heart diseases is of primary importance. And our today's webinar will going to cover the same aspect. Our endeavor is to bring the best faculties in the field of women's health ultrasound to share their clinical experience and insight. And we are privileged and honored to have Dr. Balu Vaidyanathan as the faculty for today's webinar. A very welcome to you, sir. Dr.
Thank you.
Balu Vaidyanathan is a clinical professor, pediatric cardiology, and the head of fetal cardiology division, Amrita Institute of Medical Sciences, Kochi and in Kerala. His focus areas of interest are prenatal diagnosis of congenital heart defects, advanced 3D 4D stick fetal echocardiography, training in fetal heart screening protocols. And the major career achievement are of he is official training coordinator for Government of Kerala and National Health Mission Kerala in the fetal heart training program for obstetricians and radiologists. He is also a national coordinator, fetal cardiology, working group of Society of Fetal Medicine of India and Pediatric Cardiology Society of India. He is a trainer in the fetal heart education programs of the International Society of Ultrasound in Obstetrics and Gynecology. He is also a member of Global Fetal Heart Focus Group of Wallison G Austria, Global Trainer for Wallison G in 3D 4D fetal echocardiography, ASEAN and the South Asia segments. And he has a major clinical academic achievements that he has established the fetal cardiology division at AIIMS, which is one of the largest dedicated fetal cardiology services in Asia. Also, he has pioneered the concept of prenatal diagnosis and planned delivery of neonates with critical congenital heart defects, and he has performed the first successful in utero intervention for a fetus with structural heart defect, which is the fetal balloon aortic wall dilatation in the state of Kerala. And he has delivered more than 300 lectures in various global professional platforms, including World Congress of Pediatric Cardiology and Fetal Medicine Foundation Congress, conducted more than 75 hands-on laptop-based online training workshop in fetal echo in national and international forums also. He has published more than 50 papers in the domain of fetal cardiology in various national and international peer-reviewed index journals and textbooks in the past 15 years. And he is a convener in Fetal Cardiology Working Group of Pediatric Cardiac Society of India, Society of Fetal Medicine of India, member of American College of Cardiology, Indian Academy of Pediatrics, International Society of Ultrasound in Obstetric and Gynecology, Cardiological Society of India. The lists are many, and without wasting time now I would encourage, I welcome you, sir, to this webinar, and over to you. Before that, I would encourage our viewers to keep sending questions and queries to us using the chat box. Sir will address them all at the end of the session. Very warm welcome to you, sir. Over to you.
Okay, thank you, Zeenat. That was a rather generous introduction. So without much ado, I am going to start sharing my screen and let's start the presentation. Can you see my screen now?
Yes,
sir. Only for technicals.
Okay, fine. So welcome all. This is the first of the three lectures in this webinar series on fetal echocardiography. And this is actually going to deal the common issue of diagnosis of congenital heart defects in the fetus by the conventional 2D imaging. In the subsequent workshop, we are going to talk about 3D, 4D stick fetal echocardiography and how it helps us additionally and in addition to the 2D. And we also have a session on fetal arrhythmia. Now, we all know that congenital heart defect is a very common problem. In fact, it's one of the most common congenital malformations. And in the prenatal ultrasound for detection of common birth defects, I think one of the most important challenges which obstetricians, radiologists, and fetal medicine people face is the accurate diagnosis, prognostication, and management of congenital heart defects. The prevalence of congenital heart defects is remarkably same in most of the published series. It occurs in about 6 to 8 per thousand live births, which is roughly 1 in 120. Of these, about 25% are critical congenital heart defects. Now, if you take a country like India, which has about 25 million births in a year, a large number of babies with congenital heart defects are conceived and born. Something like 250,000 will be born, of which at least 100,000 will be severe enough and can be detected in utero. When we talk about fetal heart evaluation, we can discuss different levels of expertise. The first is a primary screening for all pregnancies, which typically occurs at the level of obstetricians. And the scans are often done by obstetricians or sometimes by radiologists. Then comes a secondary level, which is the standard mid-trimester anomaly scan. And this is where most of the diagnosis is made. And very often counseling is done. And either the decision to refer to a pediatric cardiologist or not will be taken at this level. So this is the kind of most of the guidelines are focusing on this particular level of expertise. And then we have the third level, which is at the level where you are endeavoring to deliver pediatric cardiac care for the fetus, which is involving the pediatric or fetal cardiologist and a teamwork. So my focus today is going to mainly on the first and the second levels of expertise. The most common and the most sort of preferred protocol for the fetal heart evaluation is the ISWAC protocol, which is called the Extended Basic Evaluation of Fetal Heart. And as shown below in this algorithm, we can see that there are different views which we obtained, and typically it is obtained by a sweep from the caudal to the cranial direction in the transverse plane. So when we do this sweep, we see several views starting from the abdominal situs, in which you see the stomach on the left side and the liver on the right side. The aorta will be to the left of the spine and the IVC will be to the right of the spine. After that, we see the four-chamber view, in which we have a checklist to evaluate the four-chamber view, not just four chambers, but looking at symmetry, squeeze, the septa, the crux of the heart, the identification of the ventricles, the area behind the heart, and so on. Then we go to the outflow tracts, of which the first outflow is the LVOT, and specifically we look at the septo-aortic continuity in this image, and then we look at the right ventricular outflow tract, which should cross the LVOT, and then the three-vessel view, in which the most anterior vessel is PA, the middle is aorta, and the posterior one is SVC, and finally we see the three-vessel tracheal view, and typically we interrogate this view with color flow Doppler, and we see the joining of the ductal and the aortic arch in a classic V formation with the apex of the V to the left of the spine. I think these views are familiar for most of you attending this webinar, but what we are going to do in this session is we are going to actually look at the screening of the fetal heart and identification of the abnormalities, specifically using three views. That is the four-chamber view, and the situs is often included in this. The outflow tract views, which is the LVOT and the crossing of the outflows, and the three-vessel view. The three-vessel and the three-VT view are often packaged together. Most of the abnormalities, or the severe abnormalities, can be used if you correctly do these views and identify what is normal and what is not normal. Right. So the format is, I'm going to discuss 10 common anomalies, and I'll show you pictures. And in this particular session, it's not that I'm going to talk for 2 hours and you are going to listen. No, it's not going to be happening like that. I'm going to ask you questions. So before you ask me questions, I am going to ask you questions. And I expect you to answer. I'll give you the options. And then you will be responding to my questions, which is like an MCQ. We will see how you responded in the audience poll with my IT team will support me on that. And then I'm going to discuss each of this diagnosis in detail and give you clues for imaging and for diagnosing them and the possible differential diagnosis. So that is going to be the format for today, an interactive format. Okay, so let's take the first step forward and we start with the four-chamber view. So this is something which everybody is expected to do. If you are putting an ultrasound on a pregnant woman's tummy and claim that you are going to scan the fetus or doing the anomaly scan, and this is a minimum thing, minimum requirement. But this is a mighty important view. If you analyze this view very correctly, it will help us to demarcate congenital heart defects into two groups. Those who have two intact ventricles, which usually means that they are all correctable by heart surgery. And then you have the group where they don't have two ventricles, typically have a hypoplasia of one of the ventricles, resulting in what we call a univentricular heart physiology or single ventricle physiology. Such hearts can only be palliated. So a lot of information is obtained from this view. In addition, we can also look at very fine abnormalities as we see the examples later, and even pick up clues for very subtle abnormalities using the four-chamber view. So let us see the first example now. So in all my slides and all my movies, I have marked the left and right, typically using left for L for left and R for right. And also you may find this box on the screen, which is showing L for left, R for right, A for anterior, and P for posterior. And this is to orient you towards the heart. So this is a movie, and I'm going to play this movie. And you pay attention. So I'm going to give you 10 seconds for each of these movies so that you look at this carefully. It's not that you are going to look at it very passively. A question is going to come for you as soon as you finish seeing these examples. So this is the first example. The left and the right are marked. And you can see the heart. Obviously, it's not a normal heart. And then we see the color flow of the same. The left and right are marked to help you with which is the which side of the heart is what. And you can see the color flow, and something is very strikingly visible to you. So keep this image in your brain. So you saw the grayscale, and now you saw the color of the color flow mapping of the four-chamber view. So even though this is an abnormality of the four-chamber view, I'm going to show you the outflow tracts of this patient as well. So these are the outflow tracts, and what is marked as AA is the ascending aorta, and you can see the measurement also there, 2.3 millimeters, and the Z score is -7. So obviously it tells you something. And finally, the three-vessel tracheal view with color flow. The pulmonary artery is shown as PA, showing the blue flow, and aorta is shown as AO, exhibiting the red flow. So you saw all the pictures, and now this is a question for you. So the question for the audience poll, which all of you are expected to respond, and is that all the following are components of the diagnosis. I'm not going to ask you what is the diagnosis. I know you will tell the diagnosis. But what I want you to answer this. All the following are components of the diagnosis except choice A is apex formed by the right ventricle. Choice B is absence of LV inflow and outflow. Choice C is large VSD. And choice 4 is foramen ovale shunting left to right. So I want you to pick the choice which is incorrect. So I'm going to give you some time, 30 seconds. And all of you should respond. If we see very less response, then that means that you are going to see less number of cases. So I want all the people attending this webinar to respond to these choices. So choice A is apex formed by the right ventricle. B is absence of LV inflow and outflow. C is large VSD. And D is foramen ovale shunting left to right. Okay, I think that should be enough. And now I want my IT team to display the results of the audience poll. IT team, Can I have the results of the audience poll? Question number 1, please. Okay, right. So we have 62% of you showing answer C as the exception. 16% have shown that foramen ovale left to right shunt is wrong. 18% have shown that absence of LV inflow and outflow. That's the wrong answer. And 4% has actually responded that the apex is formed by the right ventricle is the incorrect answer. So let me share my screen back again. So, right. So I'm going to, can I have my screen back?
Yes, sir, you can share it. You can share it. It will overtake my screen.
Okay, so, right. Perfect. So let us see what is this diagnosis. So obviously that is a man standing on the bus stop will tell that that's an abnormal heart and this is hypoplastic left heart syndrome. And I'm surprised that even for this, only 62% got the right answer. So we'll see what are the components. So 38% got the answers wrong here. So what are the features of four-chamber view in the hypoplastic left heart syndrome? The first thing is that this is a left ventricle and the apex is formed by the right ventricle. So that is actually a correct thing. The apex of the heart is formed by the right ventricle. So choice number A is correct actually. Now when you look at the color flow mapping, you see that there is absolutely no mitral inflow, nothing. So that is also right. Choice number B is also right. And what is happening to the left atrial blood? The left atrial blood cannot cross a mitral valve. So the only exit for the left atrial blood is through the foramen ovale. So you get an exclusive left to right shunt across the foramen ovale. So that is also the correct answer. So the LV is small, hypoplastic. The apex is formed by the right ventricle. On color Doppler, there is complete absence of inflow from the left atrium to the left ventricle. That is mitral atresia. And there is a complete left to right shunt across the foramen ovale. When you look at the aortic arch, classically these patients have aortic atresia. So there will be no forward flow from the LV to the aorta. So there will be a retrograde flow into the aortic arch as shown here. That red flow into the aorta is retrograde flow. And when we look at the picture of the aortic arch in the sagittal view, so I'm showing you two pictures here, a 3D rendered picture on the bottom and the grayscale with color flow mapping on the top. AA is ascending aorta and D is ductus arteriosus, and you can see that there is a classical reverse flow into the aortic arch. This means that the aortic blood flow is completely dependent on the patency of the ductus arteriosus, and this is what is called a duct-dependent system circulation after birth. So quite obviously the 3A, B and D are correct. Now there is a variety of HLHs called HLHs with restrictive foramen ovale. So here the foramen ovale is restrictive. And in that case, what we find is that the left atrial pressure will be very high. And typically you get bulging large pulmonary veins. So these are the pulmonary veins in this and they are dilated. That's because of the fact that there is no atrial septal communication here. The blood which comes to the left atrium has no outlet, cannot go through the mitral valve, cannot go to the right atrium because the ASD is restrictive. And this can be actually diagnosed by using hemodynamic evaluation of the pulmonary vein Doppler. In a normal heart, when you put Doppler into the pulmonary vein, you typically get a waveforms like this. There will be a systolic wave, S, and a diastolic wave, and a small atrial reversal wave. That's the arrow is pointing towards a small atrial reversal wave. But in HLHs with restrictive foramen ovale, the pulmonary vein pressures are elevated and we get a very, very prominent A reversal wave. That's called AR wave in pulmonary vein Doppler. This is virtually pathognomonic of HLHs with restrictive foramen ovale. Now, what is an important differential diagnosis with which you can often mislabel as HLHs? So look at this heart. The left and the right are marked. And look at this color and look at, this is a still picture of the same. The left and the right ventricle are marked. And this is another type of heart which is HLHs. So in this entity, what we call ventricular disproportion, the apex of the heart is still formed by the left ventricle. As we can see, the red arrow is going all the way to the apex, while in HLHs, the LV is not apex forming. While in the ventricular disproportion, the RV, even though it is larger, doesn't form the apex, while in HLHs, the apex of the heart is formed by the right ventricle. So this is a crucial difference. So we need to look at which chamber of the heart is forming the apex, and this helps us to differentiate between ventricular disproportion and HLHs. The second thing which we can also do to distinguish between ventricular disproportion and hypoplastic left heart syndrome is to look at the patency of the mitral valve in color flow. Now, in this picture, we can see that there is absolutely nothing flowing into the mitral valve. You see here is completely no blood is flowing across the mitral valve. While you look at this picture, we can see that the mitral valve is clearly patent. That means that there is no mitral atresia. So the two useful points to differentiate HLHs from ventricular disproportion is the apex forming LV in ventricular disproportion and presence of a patent mitral valve inflow. So we come back to our case and discuss the answer. So the question was, all the following are components of the diagnosis except. So apex formed by the diagnosis was hypoplastic left heart syndrome. Apex formed by the right ventricle was correct. Absence of LV inflow and outflow, that was correct. Foramen ovale shunting left to right was also correct, but large VSD. Typically in hypoplastic left heart syndrome, you don't find a VSD. 62% of you got this answer right. So 38% have got work to do. So you need to understand that HLHs, they are essentially meaning a very, very specific diagnosis. So I'm not going to ask you what is the diagnosis because most of you know the diagnosis. So I have made it a little more interesting by asking you questions with except and so on. Right. Now let us move on to the second case. So this is again a very, very easy diagnosis, and most of you will say only one thing, and I will also say the same thing. So this is a 4-chamber view, and this is a picture-in-picture, one grayscale on left side and the color flow on the right side, and you can obviously find that the one chamber of the heart is pretty much enlarged. And now this is the outflow tracts. If you look carefully where I have written PA, you find a very diminutive vessel. And you can even look, if you look carefully, I hope the bandwidth is good and you can see the movie well. And even if you don't see it also is okay. The pulmonary artery is in fact much smaller than the annotation which I have put there. My annotation is much bigger than the actual PA. And if you look very, very carefully into this movie with color flow, and you look at that, there is a flash of red flow into the PA, which means that there is a retrograde flow into the pulmonary artery happening. There is no forward flow. So you saw the two pictures, the 4-chamber view and the outflow tract. Now, this is a question for you. Nothing is going to be very easy. So the questions for you is this. The following conditions can cause low pressure tricuspid regurgitation except. So the key is low pressure tricuspid regurgitation except. So the choices which you have are Epstein's anomaly, B is tricuspid valve dysplasia, and C is pulmonary atresia with intact septum. So the question is very clear. Of these three, one condition does not cause low pressure TR. Or it means one of these three conditions causes high pressure TR. So I want you to tell that particular entity. Of these three, two of them are very similar in hemodynamics, but one is different. So you have about 30 seconds to answer this. While I take a sip of water. Since the choices are only 3, maybe you can take 20 seconds. Okay, I think that should be enough. Yes, I'll give them 5 more seconds. Okay, IT, show me the results of this audience poll now. Right. Wow. So about 2/3 of you have voted for the choice C, pulmonary atresia with intact septum. And about 15% have voted for Epstein's anomaly and tricuspid valve dysplasia. Wow. So can I go back to my screen? Yes, I'm going to share my presentation again. Right, so let us talk about something about tricuspid valve pathology. So when you talk about tricuspid valve disease, most of you have only one diagnosis, that is Epstein's anomaly. And you just pack your bags and go home, write Epstein's anomaly as a diagnosis, and that's it. End of the story for you. There is another diagnosis called tricuspid valve dysplasia that is very similar, mimicking Epstein's, and we are going to have this differential diagnosis in the next few slides. And then there are two more entities. One is pulmonary atresia intact septum with TR. It can very closely mimic, and as you will see in one of those present pictures soon. And there is also this entity called ductal constriction with TR. That typically happens in late pregnancy. So let us first look at the first differential diagnosis, which is tricuspid valve dysplasia. So I'm going to play two hearts. So this is Epstein's anomaly, and this is tricuspid valve dysplasia. So what is the striking difference between the, before I talk about the differences, what are the similarities? Obviously, the heart is quite big in both. The right atrium is really enlarged. The RV also may be enlarged. And if you put color, you get a lot of TR. But what's the difference? The first is you look at the level of insertion of the tricuspid valve. So that's the first difference. Now, when you look at the anatomy of the tricuspid valve, in Epstein's anomaly, classically, the septal leaflet of the tricuspid valve will be displaced more inferiorly towards the apex of the right ventricle. So that is what you see, the downward displacement of the insertion of the septal leaflet of the tricuspid valve. So that is characterizing the Epstein's anomaly. In tricuspid valve dysplasia, the leaflets insert at the same level. There is no displacement. So this is 3D rendered picture of the same Epstein's anomaly. You can see the differential insertion. The tricuspid valve has a much more apical insertion. So you see the mitral valve is at a much higher level. While in tricuspid valve dysplasia, there isn't much of this downward displacement at all. The tricuspid valve, the normal offsetting will be maintained. That's it. So this is the first difference between tricuspid valve dysplasia and Epstein's anomaly. The second is when you put color, you look at the origin of the TR jet in color flow mapping. So this is Epstein's anomaly, and you see where the TR is coming from, and this is tricuspid valve dysplasia. In Epstein's anomaly, the TR jet appears to come somewhere in the middle of the RV cavity. That's because the tricuspid valve is displaced much more apically. That's what you see here. The TR jet arises from the middle of the RV cavity. However, in tricuspid valve dysplasia, the TR jet arises at the level of the tricuspid valve annulus. So there is no middle of the RV cavity here. The third difference between the two entities is the right ventricular cavity. Now, in this is Epstein's anomaly. You can see that the right ventricular cavity is rather small, while in tricuspid valve dysplasia, typically the right ventricular cavity is well formed. Now, the right ventricle in Epstein's is something which we have to understand very well. So it is divided into two parts. The true right ventricle is actually found in the very apex. And then there is what is called the atrialized RV due to the downward displacement of the tricuspid valve. So in this picture, the blue annotation is the true RV, while the green annotation is the atrialized RV. So that is atrialized RV, and that's the true RV. So more severe the Epstein's, the more will be the displacement, and hence the true right ventricular cavity will be smaller and smaller. While in tricuspid valve dysplasia, there is nothing like this happening. There is only one right ventricle, no atrialized RV, so the right ventricular cavity is larger. So there are three differences between Epstein's and tricuspid valve dysplasia: the level of insertion of the annulus, the origin of the TR jet, and the right ventricle cavity size. Now let us look at the hemodynamic correlates, and that will give the answer to my question as well. So this is the first scenario. I'm putting TR, and this is also severe TR. In one go, you will find that these hearts look very, very similar. The TR also looks severe. Now I'm putting Doppler, continuous Doppler or pulse wave Doppler. Some machines have continuous wave Doppler. And look at the TR jet velocity here. It is 1.8 meter per second. And if you convert this 1.8 into millimeters of mercury using the Bernoulli's equation, it will work out to a TR jet pressure of roughly about 2025. And in this case, you find that the TR jet velocity is about 6 meters per second. That is really, really increased. So this entity, the first one is called low pressure TR, and this entity is called high pressure TR. Examples of low pressure TR is Epstein's and tricuspid valve dysplasia, while high pressure TR occurs in pulmonary atresia with intact septum or ductal constriction. Now, the difference, the entity low pressure TR means the right ventricular pressure is normal. So that is the case in Epstein's and tricuspid valve dysplasia. But in PAIVS and ductal constriction, the right ventricular pressure is high. It's a hypertensive RV, and that's the reason why you get high velocity TR signal. So the hemodynamic correlation is that Epstein's and tricuspid valve dysplasia cause low pressure TR, while PAIVS and ductal constriction cause high pressure TR. I hope this is clear. So when we come to the case number 2, the audience question was, which of the following conditions cause low pressure TR except? So the answer is pulmonary atresia with intact ventricular septum, because this causes high pressure tricuspid regurgitation. Epstein's and tricuspid valve dysplasia cause low pressure tricuspid regurgitation. So we have covered 2 scenarios. Now we move on to the third one, and this is obviously not going to be so easy, but let us see. This picture can be a bit difficult. However, you can see. Again, this is not a 4-chamber view, but as we say, the stomach is the one which leads to the heart, and after some time all of us will start to get up because we'll start feeling the pangs. The stomach will start complaining. The situs will start complaining. So let me get the stomach out of the way before the hunger starts to set in. So you see the left and right, the ST is the stomach. So that's obviously on the right side. And right means it's on the correct side. And you find the aorta and IVC somewhat in this particular position. So this is what we are going to discuss soon. Now this is a 4-chamber view. And you see something here. And this doesn't need too much of explanation. The left and the right are marked. So you can see that apical 4-chamber view, there is something very obviously abnormal in this 4-chamber view. Keep watching this picture. Okay. Right? Okay. Now the outflow tracts. So the outflow tracts I'm showing, and the anterior vessel is not bifurcating and is a large vessel, while the posterior vessel, which is seen just under that, seems to be dividing. So I'm giving you a clue that what is which great artery. So you look at this picture again carefully. So I showed you picture starting from the abdominal situs, where the stomach appeared to be all right, but the aorta and IVC we will discuss. 4-chamber view was abnormal, the outflow tract looked abnormal, and the aortic arch, which is seen in this color picture, looks normal. And I'm showing you one more thing in the 4-chamber view, the same 4-chamber view. And the arrow is pointing towards an additional clue. Okay, so there are 4 clues from these images. And I hope you have seen this enough. And now let us ask this question to the audience. So all this is pointing towards clearly one diagnosis. So I'm not going to tell you what is this diagnosis, nor am I going to ask you what is the diagnosis. But tell me, all the following are components of the diagnosis except. So one of these is not a feature of this diagnosis. First option is AV septal defect. Second option B is anomalous pulmonary vein drainage. Option C is juxtaposed IVC and aorta. That means IVC and aorta are on the same side of the spine. And option number 4 is interrupted IVC. So this definitely needs 30 seconds for answering. So you saw the pictures you can infer the diagnosis, and you can look at all these four choices, A, B, C, D, and tell me which of the following components do not fit in with this diagnosis. A, B, C, or D. I think this deserves 30 seconds, maybe another 5 more seconds. Okay, I think that should be all right. So, my friend, IT friend, tell me what is the results of this particular audience poll show? Very good. So, we have 50% of you answering, 52% rather, showing that interrupted IVC is not a feature of this. 21.6%. Oh my, that's really, really surprising. Answering that AV septal defect doesn't fit in with this diagnosis, while the others is what people are saying. So let me again go back to my presentation. Okay, so this is a pretty straightforward diagnosis. This is right isomerism. So the features which I showed you which we are going to discuss is we have an abnormal situs, which I'll discuss in the next slide. There is an unbalanced AV septal defect, which again we'll be discussing. And there is a univentricular heart. The great vessels were transposed. The pulmonary artery was smaller than the aorta, so that's implying pulmonary stenosis. There was the TAPVC. In this case, it is an intracardiac TAPVC. The systemic venous connections are normal here, and there is sinus rhythm. So how do you differentiate between right and left isomerism? The actual way to differentiate is by using the atrial morphology. Typically, the RA is trabeculated, it has pectinate muscles, and the coronary sinus opens. The left atrium is smooth, there are no pectinate muscles, and the pulmonary veins open. Actually, the pathologies differentiate right and left isomerism using the appendages. The RA appendage is broad-based, while the LA appendage is slender like a finger. But these are sometimes difficult by imaging. But what you can image is the systemic veins. The classical feature of right isomerism is that you find the IVC and aorta on the same side of the spine. That is called juxtaposition of IVC and aorta. While in left isomerism, you have the double vessel sign due to interrupted IVC and dilated azygos. So that is how you differentiate between the right and left isomerism. The position of stomach, liver, heart, bronchi, etc. are not useful. Of course, bronchus will be difficult to image in the fetus. So let us look at the appendages. Now look at this picture. You see two appendages here, and I marked them as right atrial appendage. They are typically triangular with a very broad base. And this is like the LA appendage. Look at the difference, is much more slender and like a finger. It is possible to look at these appendages, but often you may miss them. So we can't often rely on appendages to diagnose and differentiate between the two isomerisms. So what we typically use is we look at the venous anatomy. So in right isomerism, as seen in this cartoon, the stomach can be anywhere, but typically the aorta and the IVC will be found on the same side. And this is what we found here. This is the midline here, what the white line, and the aorta and IVC was on the same side of the spine, on the right side here. So that is called the juxtaposition of the aorta and the IVC. So this often gives us a very good clue towards the possibility of right isomerism. In the left isomerism, typically you have what is called a double vessel sign. So you can see there over there, that's the double vessel sign, and here also you can see the double vessel sign. That is the reason because the vein is posterior, the IVC is interrupted, and the dilated azygos vein will be seen posterior to the aorta. So this is very characteristic of left isomerism, the double vessel sign. This can be seen both in the four-chamber view as well as in the abdominal situs view. So this is how you differentiate the right and left isomerism in the true sense. The intracardiac anatomy, of course, it gives clues. In both cases, you find AV septal defect. Typically, in right isomerism, you have an unbalanced AV septal defect, while in left isomerism, more commonly, you find a balanced AV septal defect. I will show you what is unbalanced and balanced in the next slide. So typically, right isomerism, since you have an unbalanced AV septal defect, you have a univentricular type of heart, while in left isomerism, often we get two ventricles. So sometimes the ventricular morphology is abnormal in left isomerism. The outflow tracts, classical in right isomerism is an abnormal relationship of outflow tract, and pulmonary stenosis or atresia is common. In left isomerism, usually we get normally related. Sometimes you get double outlet RV, and aortic obstruction is more common. And finally, pulmonary veins. TAPVC is very common in right isomerism. In left isomerism, a total anomalous pulmonary vein connection is not very common. So these are the differences in the intracardiac anatomy between the two entities. So this is what you call a balanced type of AV septal defect. There's a single AV valve which opens equally to both the ventricles. While this is what we found in this case, there was only a single AV valve, and that was predominantly committed towards the right ventricle. So a balanced AV septal defect often is found as an isolated anomaly, or it is more common in left isomerism, while unbalanced AV septal defect is a part of isomerism syndrome, usually in right isomerism. So this is IVC interruption. So you see that there is no IVC, and you can see a prominent azygos vein, and we see the two parallel vessels in the parasagittal view, and that's the dilated azygos vein. This dilated azygos vein gives the double vessel sign on the forechamber and situs view. And finally, the area behind the heart, what we saw was the confluent chamber of the total anomalous pulmonary vein connection. And in this particular case, as we can see here, the CC is a common chamber that is draining into the portal circulation. So that was an intracardiac TAPVC. So the case example which I showed you was a classical example of right isomerism, and all the components were clearly discernible. Conduction disturbances, that's typically bradycardia, is very common in the left isomerism. So this is, you are seeing a very slow heart rate. The ventricular rate is only 54, and there is evidence of complete heart block. So this is very pathognomonic of left isomerism. So case 3 was an example of right isomerism. So the AV septal defect, TAPVC, juxtaposed IVC and aorta, all are components. While interrupted IVC, of course, is not a component of right isomerism. So that is the answer here. Interrupted IVC is a component of left isomerism. So that is the case 3. Okay. Now this is a really much more interesting one. So this is again a fourth case, a right heart abnormality. So this is not very difficult to make this diagnosis. The question could be difficult. So the left and the right are marked. So you can clearly make out which of the ventricles is smaller. Also look at the ventricular septum carefully. Also look at the atrioventricular valves carefully. The left and the right always correlate with these annotations. Now here you see the color flow. You can see and clearly make out what's happening here. The inflow is what I'm interested. Look at both the inflows very carefully and look at the color flow into both the inflows. The outflow tracts, the first outflow cross from LV, that is the aorta, and the second outflow is from the RV, that's a PA. The 3 vessel view is shown, and you can see that there is a difference in the size between the PA and aorta, again suggesting something to you. So the forechamber and the outflow and the 3 vessel view are shown to you. So this is a very simple question. So I thought I'll make it very easy. I expect most of you to get this diagnosis correct. Sometimes after 3 difficult questions, it's good to put an easy question. So you have only 15 seconds to get this answer right. So the diagnosis, choice A is pulmonary atresia with small right ventricle. Choice B is tricuspid atresia with VSD and pulmonic stenosis. And choice C is tetralogy of Fallot. Right. I think we will move on to the audience poll in 5 seconds. Right. I think since this was a very easy question, I expect a lot of people to get the answer right. IT team, can I have the results of the poll, please? Okay. This is pretty much what I expected. Most of you have got the answer as tricuspid atresia. My God. Some of you have got the answer as tetralogy of fallow. That is a bit surprising. PAIVS, pulmonary atresia with small RV is okay. In fact, if that 8.5% had got pulmonary atresia, that I would have been happier. But tetralogy of fallow, I think I'm a bit really surprised with that answer, which means that we obviously have to do these sessions again and again. So let us go back to the presentation, and this is no big deal. This is tricuspid atresia. So that's the picture. The right ventricle is small. The left ventricle is obviously the bigger ventricle. The tricuspid valve is completely atretic. It's not opening at all. There is a ventricular septal defect, as you can see here. So the blood coming from the right atrium cannot go into the right ventricle. So the whole blood has to go across the foramen ovale into the left atrium. So the atrial septal defect or the foramen ovale is very, very important for the life of these babies. So when you discuss the hemodynamics, there is absolutely no flow from the right atrium to the right ventricle. The tricuspid valve is completely atretic. So the entire right atrial blood goes across the foramen ovale into the left atrium, and then it goes into the left ventricle. The only entry point into the right ventricle is a VSD. So that is very important. The VSD is actually the RV inlet as well as outlet in tricuspid atresia. Remember this statement. The VSD is the RV inlet and the outlet in tricuspid atresia, because that's where the blood is going to come into the RV, and that's the only source of the blood flow into the RV outlet. Okay. So I have drawn here two variants of tricuspid atresia. So the first variant is where you have a normally related great arteries, that is NRGA. So in tricuspid atresia with NRGA, the pulmonary artery comes from the right ventricle. So blood will come from RA to LA and then to LV, and through the VSD, the blood will go to the RV and then to the pulmonary artery. So if the VSD is small, the amount of blood flowing into the pulmonary artery will become lesser. And if there is no VSD at all, then there will be absolutely no source of blood to flow into the pulmonary artery. The second variety is the tricuspid atresia with TGA. So here, the pulmonary artery comes from the left ventricle, while the aorta comes from the right ventricle. In this case, again the same hemodynamics apply. Blood from the right atrium has to go into the left atrium and then to the left ventricle. The only entry point for the blood into the right ventricle is the VSD. So if the VSD is small, the amount of blood entering the right ventricle also will be less. And which vessel is coming out from the right ventricle here? The aorta. So if the VSD is small, the amount of flow into the aorta also will be less. So the aorta also will be small, and hence that forms a substrate for coarctation. That is the difference. So that is why in tricuspid atresia, it is not only important to look at the four-chamber view, you have to evaluate the size of the VSD, and also you have to clearly understand the great artery relationship and clearly demonstrate which great artery is arising from the right ventricle. So in the first case, in this case, is tricuspid atresia with NRGA with a small VSD. So you see the three-vessel view. The PA is smaller than the aorta, and the pulmonary artery bifurcation is seen well. And in the color flow, you can see that the aorta is having a bigger flow compared to PA. So that means that there is pulmonary stenosis here, normally related great arteries. Now let us see another example. So here we see again a lateral view. You see the right ventricle is quite small here, as shown in this annotations. And you see the VSD there, the arrow is pointing, and under color flow, you can see the color flow also. This is a small VSD. It's not a generous VSD. And now let us look at the outflows. In fact, it is a transposed outflow. You see the aorta is anterior, coming from the right ventricle. PA is coming from the left ventricle. And you look at the size of the aorta, it is quite small. So this is tricuspid atresia with TGA, a small VSD, and hence the aorta also has become small. And this is the one which can very high chance of having a coarctation or even an aortic arch interruption. So this tells you how important it is to look at the heart as a whole, not just one view and start talking about it and say that you are the expert. No. In fact, cardiology is all about understanding hemodynamics and trying to correlate with what is going to happen to this baby after birth. So this is a very, very good example of how the hemodynamics is different in tricuspid atresia based on the different type of great artery relationship, size of VSD, etc. Now, this is a very close differential diagnosis of tricuspid atresia. This is again a small right ventricle here and on 4D stick rendering. The difference is that the ventricular septum is intact here. So this is an example of PAIVS with small right ventricle. So if somebody said PAIVS, it's okay, but then the VSD was staring at you. So again, no excuses. Just like we found the foramen ovale in the hyperplastic left heart situations, in these states also, if the foramen ovale is restrictive, as what we can see here. In this case, the foramen ovale is restrictive and bulging towards the left atrium. And what will you find? The right atrial pressure will be high here. And because the blood coming to the right atrium cannot go to right ventricle, cannot go to the left atrium, so the right atrial pressure will increase, and this will reflect into the ductus venosus Doppler. Just like we saw a prominent air reversal in the pulmonary vein Doppler, in HLHS with restrictive PFO, in any right heart pathology, say tricuspid atresia, PAIVS, or whatever, if you have a restrictive PFO, you have a high right atrial pressure causing a prominent air reversal in the DV Doppler. So hemodynamics is really interesting, and it is quite possible to put Doppler in the right perspective and understand the hemodynamics in each of these entities. So that is, so we have covered HLHS, ventricular disproportion, most of the right heart lesions, PAIVS, tricuspid atresia, Epstein's tricuspid dysplasia, everything. And so this particular question number 4 was a giveaway. It's a very easy answer. The answer was tricuspid atresia with VSD. The great artery relationship was normally related, and hence there was pulmonary stenosis. Most of you got it right, but some of you, 8.5% of you, voted for tetralogy of Fallot. So now we move on to the next set of cases, that is the outflow tracts. So maybe 1 minute we will just stand up and take a few breaths, do some stretching and come back. So I need that. So I'm going to take a short break. Stand up, all of you. Hands up, down, up, down, sit, stand, sit, stand. Take 5 deep breaths. Right. You need it because you need to fill your lungs with more oxygen, because the cases are going to get a little more difficult and the questions are also going to get more difficult. Right. So let us move on to case number 5. The left and right are marked. So these are all apical 4-chamber views. So in an apical 4-chamber view, I don't need to tell you, the ventricles will be on top of your screen and the atrium will be on the bottom of the screen. So that is very easy. And this is the second picture. So the first one was the first picture at the 4-chamber view, and the second picture is at what we call the LVOT view. You can see that. And then now I'm putting the color flow. It's very, very characteristic color flow. You can see the very typical color flow. And this is a still picture. You can see even some alizing with a very big vessel coming off. Characteristic pictures. And now we see the outflow tracts. You see 2 outflow tracts. There is an anterior outflow tract which appears smaller. The middle one is big. And now you can see color flow also. So the color flow into both the outflow tracts appears to be blue. The SVC is red, so that is normal. So you saw all the pictures, the 4-chamber, the LVOT, the outflow in color, and now the 3-vessel view. Okay, so obviously there are no big guesses here. The diagnosis is very familiar to all of you. And the question for you is, all are components of the above diagnosis in the fetus. Please remember, in the fetus, except choice A is ventricular septal defect, choice B is aortic override, choice C is pulmonary stenosis, and choice D is right ventricular hypertrophy. So all are components of the above diagnosis in the fetus except one. So you have to pick the answer which is an exception. This would be a very easy one. So I'm going to give you only a very short time. Right. So let us move on to the audience poll question. Audience poll. IT team, show me the results of the audience poll. I think some people are saying that the audience poll results is not available for them. I think the audience poll result is only available to me. Because I am going to tell you because I don't want you to know what you are answering. So that is okay. Right. This is as expected. Most of you have got it right. And 85% have answered that RV hypertrophy is not the feature. Very surprisingly, 5% of you have answered that VSD is not a part of this diagnosis. 3.9% has said aortic override is not a part of the diagnosis. Those are a bit surprising. Okay, so let me go back. And so this is tetralogy of Fallot. So what are the features of tetralogy of Fallot in the fetus? So this is a normal heart, and what you find in the LVOT view is the classical septo-aortic continuity. In tetralogy of Fallot, the characteristic feature is the loss of septo-aortic continuity. The ventricular septum is shown by the dotted lines and the anterior aortic wall by the continuous bold red line. And you see that in the abnormal case, tetralogy of Fallot, there is discontinuity. Here again, the lateral view, that is the ventricular septum, and this is the anterior aortic wall. And when you have tetralogy, you have a septo-aortic discontinuity. And when there is a septo-aortic discontinuity, you get the VSD in between. That is what we call a malaligned VSD. And some of you who know me, you would have seen me, heard me describing this VSD as a conoventricular VSD. That means conoventricular means conal septum is the aortopulmonary septum, that's the anterior aortic wall, and the ventricular septum. So when there is a malalignment between the conal septum and the ventricular septum, we call it a conoventricular VSD. This is a hallmark of tetralogy of Fallot, always found. Now, pulmonary stenosis is often seen. So VSD and aortic override automatically becomes mandatory components of tetralogy of Fallot. Now, in many cases, including in the fetus, you may find that the pulmonary artery is smaller than the aorta, as we can see in this picture. The aorta is larger and the PA is smaller. And I always measure some structures like the pulmonary artery, and this is the aorta, the red. This is the main pulmonary artery. That's the pulmonary valve. That's the right pulmonary artery, and that's the left pulmonary artery. So you take these absolute measurements, and you also compute the Z-scores, and that's based on the gestational age. And this will tell you how small or large a particular structure is with this expected measurement for the gestational age. Very often, the MPA to aorta ratio is helpful in assessing the severity, and it is also useful in assessing the progression of the pulmonary stenosis. So I'm going to show you the normal MPA aorta ratio. So this is a normal heart, and the MPA aorta ratio is about 1.16. The PA is bigger than the aorta. So this is an example of a mild TOF. The MPA aorta ratio is about 0.7 or above, and then you have a very severe TOF where the MPA aorta ratio is less than 0.5. Now, when you say that the PA aorta ratio is less than 0.5, you're implying that the pulmonary stenosis is very severe, and the baby is likely to have significant cyanosis at the time of birth. Now, these are the clues, imaging clues for severe TOF. Now, this is only severe clues for severe TOF. Please do not take home the message that these are markers of poor prognosis. If anybody listening to this lecture henceforth calls severe TOF as poor prognosis, that's wrong. Severe TOF only means that the baby is likely to need a newborn intervention, and we are there to take care of that. And you can easily handle the situation, and once the obstruction is relieved, the baby will behave like a normal TOF only. So these are the clues: the MPA aorta ratio of less than 0.5, the Z scores of pulmonary artery, RPA, LPA less than -3, and if there's a progressive decline in the size of the PA. Second is color flow patterns. So if you put the color into the outflow 3-VT view, and if you find minimal or no antegrade flow or retrograde flow, here you see retrograde flow, that means that this is really severe TOF with duct dependent circulation. This baby has to be delivered in a cardiac center so that an immediate newborn procedures may be needed. And finally, some people have looked at pulmonary valve peak gradients. Typically, at 20 weeks, if the gradient is more than 90 centimeters per second, and at 34 weeks, more than 145, some people have used these to define severe TOF. I don't find that very useful. For me, the size of the PA and in particular the color flow patterns give the more useful clues. So whenever you find features of severe TOF, it is better to transfer that delivery, do an in utero transfer and deliver the baby in a cardiac center so that the pediatric cardiologist can immediately attend and take care of the baby. The prognosis is very good even for severe TOF because once you salvage the newborn situation, the subsequent surgical correction is just like regular tetralogy of Fallot. We did do different procedures like a balloon dilatation of the pulmonary valve or a stenting of the right ventricular outflow tract or sometimes a ductal stenting in severe TOF depending upon the choice of the centers. So the audience poll question, the answer obviously was right ventricular hypertrophy. Right ventricular hypertrophy develops much later, typically after birth and sometimes as the child becomes older. A newborn with tetralogy still may not have an RVH. So VSD, aortic override and pulmonic stenosis are all components of the diagnosis. So we are actually doing well. We are exactly midway through our webinar and I hope everything is going well. Zeenath, is everything well? Just asking you this question, Zeenath?
Yes, sir. Everything is fine, sir.
All the audio, video, everything is going well?
Yes, it's going great, sir.
Okay, great. Okay, fine, good. Okay, now this is case number 6 and this was referred as abnormal outflows. So I'm showing you the 4-chamber view and the right and the left are marked. And now you see the first outflow tract which is coming from the LV. You look carefully. Normally the LVOT has a very peculiar kind of orientation. In this case, it appears to be different. And now this is the second outflow which is arising from the right ventricle. So it's easy to spot the ventricle where R is, that's the right ventricle. And now you see the second outflow coming from the right ventricle. And you have the 3-vessel view, very characteristically you see there. So you have all the components of the diagnosis, the normal 4-chamber view and not so normal first outflow. The second outflow from the RV also is not normal and you have a very characteristic 3-vessel view. Now the question for you, there are only 3 choices here, so it makes your life easy. What is the most specific sign for the diagnosis of this lesion? That is a question. So that is the interesting twist. So again, I'm not going to ask you what is this condition. So what is the most specific sign for the diagnosis of this lesion? So choice A is absence of crossing of outflow. Choice B is a single outflow seen in 3-vessel view, the so-called I sign. And choice C is the first outflow from the LV bifurcates, the anterior outflow continues as the aortic arch. So your question is, you have to tell me what is the most specific sign for the diagnosis of this lesion from the choices A, B, and C. So you have about 30 seconds for this. We are very well on time. Okay. Now let us go to the results of the audience poll. The audience need not worry about that some of them have actually sent me a feedback that they are not able to see the results. but that is going to be visible for me only. Excellent. Wow, this is a very trick question, and the answers, the most specific sign for the diagnosis, 46% has written absence of crossing of outflows. 18.7% have told that the I sign is the most specific sign, while 34% have shown that the choice C, the first outflow from the LV bifurcates and the anterior outflow continues as the aortic arch. So let us see the discussion of this case. So I'm going to go back to my presentation. So obviously the diagnosis is TGA. So let us see the LV outflow tract. So this is a normal outflow tract. The first outflow is typically the RV, and it comes from, the first outflow is the aorta. That comes from the LV. And characteristically, the aorta goes towards the right shoulder. And what did we find here? In this case, the first outflow tract was actually moving towards the spine, posteriorly. So, and you can also see that that was bifurcating. So the first outflow was bifurcating and it was running posteriorly. So the first outflow tract is pulmonary artery, and that is coming from the LV. Now let us see both the outflow tracts. So you are seeing both normal and TGA. Now in normal, you will find that the aorta goes towards the right and pulmonary artery goes towards the left, and there is a crossing. TGA, the pulmonary artery is from the LV going posteriorly, and the aorta is from the RV, is a more anterior outflow. So most of the TGAs have parallel outflows. That is true. That sense it is true. But as I am a pediatric cardiologist, so in some cases, obviously, you may find that the outflow tracts can actually even cross in TG. We have found such situations. So in actual pathology specimens, crossing can be sometimes found because it's a route. So in a strict sense, your answer is okay for an imaging perspective. But in the real sense, the truest sense, the answer is the pulmonary artery comes from the LV and the aorta comes from the right ventricle. So that is the true sense, the answer in TGA. So this is a normal outflow. The right ventricle gives rise to PA, and that continues as a ductus and into the descending aorta. While in TGA, the right ventricle gives rise to the aortic arch, ascending aorta, that continues as transverse arch. And from these pictures, you can see how different is the configuration of the two arches. The ductal arch is more like a hockey stick, while in the aortic arch is more like a rounded shape. So if you have that characteristic aortic rounded arch coming as the anterior arch from the right ventricle and a bifurcating PA as a first vessel posteriorly, that is a hallmark of TGA. So this is again a beautiful rendered picture. As you can see here, a picture of the aortic arch, which is classically the anterior. AAO is ascending aorta, TA is transverse arch, DAO is descending aorta. You can even see the branches of the arch coming, and this is really characteristic, that aorta coming from the right ventricle. Now, so if you say absence of crossing, it is okay. I mean, I will give you half mark or maybe even 3/4 of a mark. I sign, I will come to that. I'm going to dismiss that sign. But obviously, the most appropriate answer is the PA arising from the left ventricle, that's a bifurcating vessel, and the aorta is anterior outflow, and that continues as the aortic arch. Now, in transposition, when you do this imaging in the late pregnancy, particularly in the third trimester, you should look at the foramen ovale. And in this paper, which is published way back in 1999 from France, described the possibility of in utero restriction of the foramen ovale and even sometimes ductus arteriosus. So this is ductus arteriosus. And if it's a very unfortunate baby, both of them can become restrictive in utero within the same fetus. That is a real brute of a case, because these babies are going to present with extremely severe cyanosis, and they are going to be really, really difficult to manage. Some of them may need an immediate resuscitation, shifting to the cath lab for an emergency balloon septostomy, and these are very, very high risk fetuses. So it is very important that this is done in all transpositions in the third trimester. There are some other ways to look at it, like pulmonary vein Doppler, but I won't discuss those. But please look at this foramen ovale and ductus arteriosus in third trimester in TGA. Nevertheless, all TGAs should be delivered in a pediatric cardiac center. There is no question about that because you never know when these become restrictive. Now, this entity called CCTGA, obviously the difference between a DTGA and a CCTGA is that in DTGA, which is complete transposition, the four-chamber view is normal. But in CCTGA, you have an abnormal four-chamber view where the right ventricle will be on the left side. So the pulmonary veins will be going into the left atrium, and left atrium connects to the right ventricle. So the left-sided valve will be at the lower level because the tricuspid valve will be at the left side. So that is what is called the reverse offsetting. So sometimes it is very important to look at the four-chamber view in TGA. You may get very excited with the fact that you don't have crossing of outflows. You find the PA arising from the LV and the anterior outflow is the aorta. You get excited. You say, oh, this is TGA. But if you sometimes you miss the four-chamber view, and if there is a reverse offsetting in the four-chamber view, then you have again AV discordance and VA discordance, that is double discordance, that is corrected transposition. So in CCTGA, you have the left atrium connecting to the right ventricle and the left AV valve inserting at a lower level, and the right atrium connecting to the left ventricle and the right-sided AV valve inserting at a higher level. So that is the CCTGA, and that's very important to look at that. Obviously, the outflow tracts in CCTGA will be very similar. The first vessel will be PA from LV, and the aorta will be from the RV. So we come to this so-called I sign. This is something which has been described as synonymous with TGA. Yes, it is important because it gives you the clue that this could be transposition, and perhaps the most important condition to be understood when you get this I sign is TGA. However, it's non-specific. It can be seen in any lesion where the outflow tract are transposed, like complete TGA, CCTGA, sometimes even in a DORV TGA. And I will show you examples later, top pulmonary atresia, common arterial trunk, where there is a single outflow. That can also very remarkably produce a very similar picture. So this screening view, the so-called I sign in the three-vessel view, yes, it does gives a very useful imaging clue for TGA, but it is not a very specific sign for TGA. It can be seen in any other condition like what I have described below. So the most specific sign, that is the question number 6, the absence of crossing is actually okay. It is reasonably specific, but not the most specific. The I sign is certainly not specific. It's a sensitive sign. That's what we call it. Sensitive to pick up TGA, but not specific. But the most specific would be that the first outflow from the LV is a PA. That's bifurcating. And the anterior outflow is aorta. That's continuing as the aortica. That's a very specific sign. Now we move on to the 7th case. So this is the four-chamber view. The right and the left are marked. Looks remarkably normal. And now you look at the outflow tract. What's happening here? You can see the left and right, and the outflow tract is also nicely seen. And now you have the I sign for you again. See, another I sign here, the outflow tract here. So that's the I sign here. And when we put color flow on the outflow tract, this is what you are getting. So you see a very large vessel coming off, and then you see something else as well. The left and the right are marked. So you saw the sequence, the normal looking four-chamber view. The LV outflow, you showed something. There was the I sign very prominently seen on the three-vessel view. And on color, you are seeing this picture. So what's the diagnosis? And this is a trick question for you. In fact, this is a good question. Now, I'm sure that there will be a variety of answers here. So since we have I sign, transposition of great artery is possible. Again, since we have I sign, DORV TGA type is possible. Yes, since we have I sign, a trough with pulmonary atresia is possible. There's one outflow. And since we have I sign, common arterial trunk is also possible. So tell me what's the diagnosis here? So you can take 30 seconds for your answer. Okay, I think that's enough. So let us go to the results of the audience poll. My friend IT, show me the result of the audience poll. Wow, this is great. So I think this is great. So 2.3% said the diagnosis is TGA, 18% said the diagnosis is double outlet right ventricle, 11% said the diagnosis is TOF with pulmonary atresia, and 69% said the diagnosis is common arterial trunk. Okay, so I'm not going to give the answer yet, but let us just continue with our presentation. Okay, right. So this is what we saw. Actually, you have the four-chamber view without color is exhibited here. The left and the right, you see a very large outflow, which is overriding the VSD here. It's very clearly seen. And in fact, you can see in the still picture, two small arteries as well, bifurcating. See that bifurcation? The right pulmonary artery is 1.8 millimeters, the left is 1.5 millimeters, and they are small. And when we put color, you note the direction of flow into the PA. The blue is into the aorta. And you see that retrograde flow into the PA? So that blue is into the aorta. And you see that's the aortic flow. And you see what's happening in here? That's a reverse flow. So there is a single outflow tract, which is a huge vessel, non-bifurcating, and there is a retrograde flow into the smaller vessel, which is pulmonary artery. So it makes very easy. So that is the case which we saw. This is a differential diagnosis. Here you see again a normal four-chamber view, a large vessel overriding. That's the continuing as the aorta. The pulmonary artery seen arising from the aorta. And you look at the color flow, blue into the PA and blue into the aorta. So in this case, what I showed you was a case of a VSD with a single outflow, which is overriding the VSD. And the differential diagnosis of this entity is there are two conditions only, common arterial trunk or truncus arteriosus and TOF with pulmonary atresia. How will you differentiate? In truncus arteriosus, there is only one trunk, and that continues as the aorta and gives rise to the PA. So obviously, since the direction of flow is same from the ventricle into both the outflows, the direction has to be same. In TOF with pulmonary atresia, there is a single outflow, that is the aorta, and pulmonary artery is actually fed by the ductus arteriosus, the classical case, and hence the flow is reverse. So in trunk, this is pulmonary atresia, antegrade flow into the aorta and retrograde flow into the PA. And this is truncus, antegrade flow into the aorta and antegrade flow into the PA. So most of you got this answer wrong. You said common arterial trunk and you missed the retrograde flow of blood into the PA. That is so very well nicely shown here. And this, I remember my very dear friend Chandrasekhar Kenjale. He's one of the most wonderful radiologists which India has ever produced. And he's no more with us. He was such a close friend of my heart. And I've seen Chandrasekhar actually presenting this differential diagnosis so elegantly. In fact, he described this whole so beautifully that then I actually walked onto a stage and said, you are better than many pediatric cardiologists in understanding this fetus. So it was classical case demonstration of differential diagnosis of a single outflow common arterial trunk versus TOF with pulmonary atresia. The major clue is that in TOF with pulmonary atresia, aorta gets antegrade flow, pulmonary artery gets retrograde flow. So that's a reverse flow. While in common arterial trunk, both the outflows get same direction flow. So I think this has made it clear that the answer for this question is TOF with pulmonary atresia. I think most of you got this answer wrong. Only a very small proportion of you, 10% of you only got this answer correct. So that is again a very, very important differential diagnosis. Right. So now we move on to the 8th case, and I promise you the cases are only going to get a little more and more difficult and interesting now. So this is the 4-chamber view, and you can see the left and right are marked. Anterior and posterior are also marked. This is the color flow, and believe me that there is a flow into the LV. So this is a 3-vessel view and the 3VT view also. So the PA is on top, and I have marked them as well. The aorta is in the middle. You see the PA and aorta, and you can compare the size of the PA and aorta also. So the 4-chamber view gave you a clue, and this is a 3-vessel view, and this is a 3VT view in color. And the PA is on anterior, and you can see the size. The aorta is seen there, and you can look at the size of the aorta as well. So I've given you 4-chamber view, 3-vessel view, and a 3VT view in color. So you can actually make up your mind about what is the likely diagnosis. Okay, so again, what is the most specific sign of this anomaly? So I want you to make the diagnosis and tell me what is the most specific sign of this anomaly. So the options for you are option A, ventricular disproportion in 4-chamber view with LV smaller than the RV, which you saw in the 4-chamber view movie. The LV was slightly smaller. The second option for you is 3-vessel view showing an aorta smaller than the PA, which also you show. The third option is isthmus shelf with flow turbulence. And the fourth option, D, is reverse flow into the aortic arch. So which of this is a more specific sign of this anomaly? Most specific sign. So you will take 30 seconds for answering this question. Some of this may look very attractive, but that is obviously not a feature of this diagnosis. There are conditions which mimic this diagnosis, but that is different. Okay, so I'm going to tell that as well, but this is a particular diagnosis, and now I will go to the audience poll. IT, can you show me the results of audience poll for question number 8? Excellent. So I will read out the answers. 8% have responded that it's a 4-chamber view, ventricular disproportion is the most specific sign. 26% felt the most specific sign is aorta smaller than PA in the 3-vessel view. 40.6% have written that the isthmus shelf with flow turbulence is the right answer. And 26% have written that reverse flow into the aortic arch is the right answer. So let us say whether the audience wins this round or not. Okay, so the diagnosis of this is coarctation of aorta. So the screening for the coarctation is typically the 4-chamber and 3-vessel. 4-chamber shows ventricular disproportion with smaller LV, and 3-vessel shows a smaller aorta. More specific will be the 3-vessel tracheal view, where the isthmus is small and the duct isthmus ratio. I'll come to the next slide. So a smaller isthmus. The high likelihood of surgery, in fact, the highest likelihood is a serial reduction in the isthmus size and the presence of isthmus shelf with the flow disturbance. That's the most specific sign. So the answer is also clearly explained. So the clues from four-chamber view is very, very obvious. Ventricular disproportion. LV will be still apex forming. Some cases, as what we are seeing here, you may find a dilated coronary sinus. We can see that in this picture where the arrow is pointing. That is usually due to persistent left SVC. But this is very non-specific. It just gets you started with the possibility of coarctation. A useful tip is a three-vessel view, where you find the aorta smaller than the PA. You should look at the Z-scores, and you compare the size of the aorta and the SVC. If the aorta is smaller than the SVC, that is an incredibly small aorta. Very high chance of coarctation. And in the 3VT view, you find the small isthmus, very small isthmus. SA, you can see the aorta and PA are marked A and P, and the isthmus is I and the duct is D. The isthmus to duct ratio, if it is less than 0.7, or the isthmus Z score is less than -2, or if they are coming lesser and lesser as the pregnancy is advancing, this is a very, very useful sign. But the most specific sign is this isthmic shelf, and where you get the classical coax shelf. And if you have flow disturbance, you get, that's where the arrow is pointing, the isthmus shelf. This is very, very specific, and that's how we can actually pick up coax. But all this is a paper which was published in Circulation. They looked at all the possible signs and specific signs, and they found out that isthmus shelf with flow disturbance is the most specific sign for fetal coarctation. Now, interrupted aortic arch, so that is the elder brother of coarctation. So you see this three-vessel view here. SAP is S for the vein, and A for the aorta, and P for the pulmonary artery. T is trachea. So what do you find here? The aorta is actually not extending further down at all. Only the pulmonary artery is going all the way to the spine. The aorta is stopping short. That means it's interrupted. And that's where the interruption is. And what typically happens is the ascending aorta, that is marked here as AA, has a straight course into the neck as the innominate artery. That's a very classical picture. And when you put the 3VT view color, and this is coarctation, you can see the aorta as A and pulmonary artery is P. You can see the isthmic shelf, and you find that the direction of flow is same. This is interruption, the reverse flow. Typically, that reverse flow occurs when there is absolutely no antegrade flow in the aorta. That is more of a feature of interrupted aortic arch or transverse arch hyperplasia than coarct. In coarctation, typically the flow tends to be mostly antegrade. So the reverse flow is more of a feature of arch interruption or extreme coarct, which is almost like a interruption itself. So that is the reason why the most specific sign would be the isthmus shelf with flow disturbance. So in question number 8, I think choices C and D are pretty good, but as per the data for coarctation of aorta, this case was coarctation. It was not interruption, because you could see that in the 3VT view, both aorta and PA had blue flow. So the isthmus shelf with flow turbulence is the most specific sign. Right, so it has been a pretty long session. Now we have half an hour more. So I'm going to go to the final 2 cases. So this was a primi gravida referred because of right aortic arch. So this is a 4-chamber view which looks normal. This is the LVOT coming off. It looks good. 3-vessel view. This is giving you the first clue. The aorta and the PA are marked. They look same size, but there is something which is not normal here. And the color also is seeing. Look, they seem to be going away, or not really. They don't like each other, it seems, in this case. And the 3VT view is showing some kind of funny pictures. First something like a U, and then there's something else coming up. And finally, this is a 3VT view fully. You see here. And this is a rendered kind of a picture. And this is a picture which I would want you to see a little longer. Look at this carefully. Okay. So that is a clue. So you have a normal 4-chamber view, 3-vessel view. There was something between the aorta and PA. And the 3VT view with arches, this is a picture. Now the question for you, this is a pretty easy question. Which of the following is a complete vascular ring? Complete vascular ring. Choice A is right aortic arch with a left-sided ductus. Choice B is right aortic arch with an aberrant subclavian artery. Sorry, it's an aberrant left subclavian artery, not aberrant right. It's an aberrant left subclavian artery. I apologize for that error. Choice number C is a double aortic arch. And choice number D is right arch with the right-sided ductus. So which of the following is a complete vascular ring? Choice B, please correct that aberrant subclavian artery is an aberrant left subclavian artery. So maybe I will do the correction right now. Right, so there are no more excuses. These are your choices. Aberrant left subclavian artery. Okay, let's go on to the audience poll of this question. IT, give me the results of the audience poll for question number 9. Right, not surprisingly, most of you got the answer right, double aortic arch. So that is expected. And right arch with aberrant, sorry, it's all right, it's aberrant left subclavian. That's okay, that's not a big deal. So let us, but some of you have actually got right arch with left-sided ductus, right arch with the right-sided ductus, all as complete vascular ring. Okay, so that is not obviously the right answer. So let us see this case. So this is a normal 3-vessel view, and this is what you get in right aortic arch. So the first clue for the right aortic arch comes from the 3-vessel view, where you find an increased gap between the aorta and the pulmonary artery. And that is very evident here. Even in a color flow picture, you find an increased gap between the PA and the aorta. That's because the PA is left and the aorta stays on the right side. Then when we move on to the 3VT view, so this is a normal 3VT view. P is pulmonary artery and A is aorta. They converge together as a V-like formation, and the V, apex of the V will be on the left side of the spine. But in the right arch with the left-sided ductus, typically you have the U sign. That is what you saw here, the U sign. And this is a color flow of the right arch with the left ductus. This is a normal left arch. And in the right arch with the left-sided ductus, typically you have the U sign. That is what you see. But this was not that U sign here. And here, what did you find here? This was the picture which I showed you. Here, A is ascending aorta and P is the pulmonary artery. The aorta is dividing into 2 arches. The R is a larger right arch and the L is a smaller left arch. The D is a ductus arteriosus. So, and this is a rendered picture. The aorta has bifurcated into the left, the right arch. You can see it very nicely. And there is a ductus also. So, this is what is called a lambda sign. The aortic arch divides into the larger right arch and a smaller left arch. The left arch will be anterior to the trachea. The ductus is left-sided. So typically the trachea will get compressed between the 2 branches of the aortic arch, and thus it forms a complete vascular ring. So there is no doubt about the fact that the correct answer, the complete vascular ring, is the double aortic arch. In most cases of double aortic arch, the dominant arch tends to be the right arch. Usually presents after birth with stridor or dysphagia, and what we have to do is to divide the smaller arch, which is typically the non-dominant left arch is divided to relieve the vascular ring. So I'm just sort of minimizing and giving you the right, making a small correction here. Go back and play this. Right. So the choices which I gave you were right arch with left-sided ductus, right arch with aberrant left subclavian artery, a double arch, and right arch with the right-sided ductus. The correct answer was double aortic arch. That's the complete vascular ring. So it's important to make this diagnosis in utero because these babies can have significant stridor at birth, which will require surgery. So this is the last case, and this obviously is not going to be a very easy case. So let us see how many of you get this one right. This one, people who get this right will get some special sort of gifts. So this is the four-chamber view, and this patient was referred for right heart enlargement. And you can clearly see that there is something in this. Definitely, you can see that the RV looks bigger. So this is the four-chamber view. So this is a three-vessel view. We say three-vessel view, but there is more than three vessels here. And what is very interesting in the color flow is you note the color flow. One of those vessels is red and the other one is blue. And there's even something happening, very interesting happening. Four vessels. You see 1, 2, 3, 4. And you see, look at the direction of flow as well. Now we see the bicaval view, the SVC and the IVC. Normally they are of equal size, but here look at the difference in size. The SVC is a giant vessel view. So you have ventricular disproportion in four-chamber view. You have four vessels in the three-vessel view with a very characteristic color flow pattern in the two venous vessels. You find the SVC is big. And there are some more clues on the four-chamber view. Look carefully. No arrows yet. Look carefully at the four-chamber view. This I am going to play for some time. The subtle clue, if you look carefully at the four-chamber view, at the area where you are supposed to look, you will get the clue. Okay, I think most of you would have looked at this, even allowing for the lag in the internet. Okay, so case number 10. What is the diagnosis? Choices are persistent left SVC is A. B is double vessel sign with interrupted IVC. C is total anomalous pulmonary vein drainage to the SVC. And fourth, and D is the vein of Galen aneurysm. So I put one diagnosis outside the heart and three cardiac diagnoses. And I'll give you 1 minute to answer this question. So you had a dilated right heart. You saw four vessels in the three-vessel view. You saw a dilated SVC. And the four-chamber view revisited. There was something else as well, an additional clue, which was actually very obvious in that color still picture which I showed. Okay, so that is the time is up for that. So for the last time, IT, my friend, show me the results of the audience poll. So we had persistent left SVC, we had double vessel sign as an interrupted IVC, TAPVC, and vein of Galen. Wonderful. I think all of you deserve prizes. It's extremely surprising that for an answer which I really expected most of you to answer correctly, that the common arterial trunk, a lot of you got that wrong, but here a lot of you have got things right. 75% have written a TAPVC, 8.5% have written persistent left SVC, 9% have written double vessel sign, an interrupted IVC, and 6.6% have written vein of Galen aneurysm. So I'm going back, and now let us see this entity. So here I want to bring to your attention the brachiocephalic vein view. So this is a very useful clue for systemic and pulmonary vein abnormalities. It is formed by the confluence of the left jugular and subclavian veins, and it is seen further anterior to the three-vessel view, and it crosses the mediastinum, and the left brachiocephalic vein drains into the SVC. So that is the BCV. So it is seen anterior to the aortic arch. So it's further anterior to the aortic arch. This is in fact the most anterior structure which you can see in the fetal heart imaging. So when you have the variations in BCV, you have the differential diagnosis between persistent left SVC and TAPVC. So when you have 4 vessels in the 3 vessel view, the most common condition you think of is the persistent left SVC. So in this picture, you have PA shown by P, aorta by A, SVC by S, and then there is this additional vessel which is marked as L. Now, the second is dilated BCV. Typically, when you have a dilated BCV, you have 2 conditions, TAPVC or vein of Galen aneurysm. While typically in the persistent left SVC, the brachiocephalic vein is not present. It is absent. The reason is because when you have 2 SVCs, you don't need the brachiocephalic vein. There will be one right SVC and one left SVC and no connecting vein. So typically in persistent left SVC, you don't have brachiocephalic vein, while in the TAPVC, you have a dilated brachiocephalic vein. So 4 vessels in the 3VT view, 2 important differential diagnoses are TAPVC and persistent left SVC. The brachiocephalic vein helps you to differentiate the 2. In persistent left SVC, there is no brachiocephalic vein, while in TAPVC, it is typically dilated. The second clue comes from the direction of flow in the 4th vessel. In the persistent left SVC, the additional vein typically drains towards the heart. You'll get the blue flow. While in the TAPVC, the 4th vessel, that will typically drain upwards. It will be draining away from the heart, towards the SVC. That is towards the supracardiac TAPVC. So the direction of flow will be reversed, that's red. So that is what we found in our case when I put color. One of the veins had blue flow while the other had a red flow. That is, it was a vertical vein which is ascending up. So here we can see it beautifully here. That's the dilated brachiocephalic vein, and you can see that nicely joining the SVC. So this is an example of supracardiac TAPVC. Very, very nicely seen. And this is a rendered picture of a different case. You can see the vertical vein, the dilated brachiocephalic vein draining into the SVC. And CC is a common chamber. In fact, you can see actually the individual pulmonary veins also joining and ascending up into the vertical vein and joining the innominate vein and draining into the SVC. So the clues for supracardiac TAPVC are the area behind the heart first. You see a collecting or the common chamber. So that is very important. Normally between the left atrium and the descending aorta, you don't find any structures, but here you could see the common chamber. The 3 vessel view, you get 4 vessels. That is the 4th vessel. And that 4th vessel typically will be anterior to PA. Dilated SVC in the bicaval view, and finally a dilated brachiocephalic vein in the BCV. When you put all of them together, the diagnosis is supracardiac TAPVC. You can get infracardiac TAPVC very similarly. In that, the difference is that the IVC may be dilated, and you will see the common vertical vein will be draining downwards towards the IVC. And I showed that example when I showed you the picture of right isomerism. So the answer for this question was TAPVC to SVC, or supracardiac TAPVC. So most of you got this answer correct. Now, I have completed the 10 scenarios and I have discussed differentials around that. I felt it is much better to discuss this way rather than just talking about some diagnosis and showing some pictures, which is a usual way. So I'm going to add a few points about how do we counsel. Now, any evaluation of the fetus, it's not just the heart, it's the fetus as a whole. Nowadays, I join most of you in the fact that we need to start this process very early. In fact, I am a very strong advocate for the first trimester screening now. You should do the NT scan for every single case. You should do the double or triple markers. You should also look at the basic anomaly during the first trimester. And that will help you to differentiate the pregnancies into high risk and low risk. And anybody who doesn't pass the first trimester test needs to be evaluated in detail. And if there is a need for doing a genetic test, do all that. So even before we go to the heart, it is important to look at the fetus as a whole, extracardiac anomalies, genetic anomalies, etc. After that, you start with the 4-chamber view. Anybody who has an abnormal 4-chamber view, where one of the ventricles is hypoplastic, we are looking at the possibility of a complex heart defect, typically of the univentricular heart physiology. That means that they are only subjected to palliative procedures after birth, and hence they do have a long way ahead with difficult life. However, if the four-chamber view is normal with two intact ventricles, you are looking at the possibility of a heart defect which can be completely corrected after birth with surgery. Classical example is TGA. Then you look at the outflow tracts, you look at their number, their relationship, and whether they are obstructed. So you get a number of conditions in the outflow tracts like tetralogy, TGA, DORV, coarctation, and so on. And you also need to fathom and factor in the possibility that whether this lesion can progress in utero. For example, a tetralogy at 22 weeks can progress towards a more severe tetralogy or even a pulmonary atresia as the pregnancy advances. Same way, a ventricular disproportion can progress into a coarctation. So that is important. And finally, what is the most important thing is that towards the third trimester, when you evaluate, you need to look at the possibility whether this baby can present with the critical circulation at birth, like what we call duct-dependent circulation. And this is where the 3VT view is exceptionally important. If you have reverse flow into one of the outflow tracts, like aorta means it's aortic obstruction, PA means it's PA obstruction, transposition, look at restrictive foramen ovarian transposition, and all this means that it's a very critical circulation, and such babies should be only delivered in a pediatric cardiac center. And this is the counseling algorithm which I would recommend. And the four-chamber view, obviously, I'm coming back to that. It's a very important view. So it picks up simple things like HLHs or Epstein's or right isomerism. These are all looking at very complex, severe diagnosis, and this should be diagnosed early in pregnancy. While the outflow tracts looks at correctable lesions mostly, like tetralogy or transposition or coarctation, and most of them are correctable, and some of them like TGA and coarctation are critical as well. So if you want to put all congenital heart defects in the fetus, the first group is of course things like small VSD which are not even worth mentioning in the fetus, mild pulmonary stenosis, bicuspid aortic valve, persistent left SVC. These are all very, very small things. And these are not, I would not want to discuss this in the context of a fetal heart, CHD discussion, because these are really, really benign conditions. If you pick up a small VSD, so be it. Many of them will close in utero itself, or they will close after birth. So you don't need to terminate such pregnancies for that. So you just tell them that, yes, it's a very small benign lesion. You should get an echo just to confirm everything after birth. Then you have situations like, lesions like a large VSD or coarctation or TAPVC, which is non-obstructed, typically have very good prognosis. I put ASD because I'm just talking in terms of a primum ASD. The secondum ASD is, of course, cannot be diagnosed in utero. These are all lesions which have excellent outcomes, near normal life expectancy. Then you have entities like tetralogy, TGA, most of DORVs, obstructed TAPVCs, coarctation in the newborn. All of them have very good prognosis. They are all, they can be corrected totally, what we call feasible for anatomical repair. 95% is adult survival. All these conditions, there may be a 10% chance of reoperations, particularly tetralogy or TGA, DORV type of TGA, etc. But mostly these are all things which we can really salvage well. Now when we move on to more difficult entities, and most of them have either a single outflow, like a TOF pulmonary atresia, or a common arterial trunk. Some of the single ventricle hearts, like univentricular hearts, like tricuspid atresia, where the left ventricle is the single ventricle, complex DORV, most of these entities have a need repeated operations. Either they can only be palliated, or if you are doing an anatomical repair, like a TOF pulmonary atresia, we need an artificial graft called the conduit to bridge the missing pulmonary artery. For common arterial trunk, also there is only one outflow, and you need a conduit from RV to PA. So that means that reoperations are universal here, and they have about 85% adult survival. So I will put their prognosis as reasonable. However, you have some entities like hypoplastic left heart syndrome, heterotaxy, that's the other word for isomeric hearts, very complex forms of pulmonary atresia where you don't see pulmonary arteries, MAPCAS, newborn Epstein's. These are all really difficult cases, and either the repairs are very complex, Maybe somebody else may argue that their survival are improving, but in most situations, these are difficult, very, very difficult, especially entities like hypoplastic left heart syndrome. And these are the lesions one should try to pick up very early in pregnancy so that all options can be discussed with the family. So, pediatric cardiology and newborn cardiology has received a great blessing with prenatal diagnosis. This is a baby, newborn baby, who is in our ICU recovering after an arterial switch for TGA. Nowadays, in our center, prenatal TGAs are operated on the third day of life, and by 10th, 12th day, they are discharged. They are so well, and most of them do well. So, it is very important that don't see all congenital heart defects as a fetus as the same thing. No, they're different. You need to understand the difference in the outcomes, the treatment options between all the different entities. So the starting point for you is to make the correct diagnosis. And after the correct diagnosis, counsel correctly and counsel scientifically. Don't put your judgments onto the counseling. Counsel according to what science is telling you. Do not hesitate to refer the patient to a pediatric cardiologist for a second opinion, especially in correctable problems, and then the management can be taken over with the multidisciplinary team. That is my message. I think we are succeeding very well through these webinars, and I thank all of you for listening to this program. We have about 10 minutes left for the question and answer session, and I'll hand over to the IT team and the coordinator for the question and answer session.
Yeah, thank you very much, sir. It was a wonderful and interactive session. I'm sure that audience and the viewers would have enjoyed this polling and the question answers thing. So it will refresh their knowledge about the fetal heart, and many of them have learned how to do that. So there are, sir, we have received many questions are there. So I would take it one by one to you.
Okay. So I'm going to actually use the whiteboard now. Yes, let us have the whiteboard just in case. Okay, can they see the whiteboard now?
Yes, sir, it's visible.
Yes, sir.
Okay, fine. So let us have the whiteboard in case something is needed. Yes. So we have 10 minutes, Zenith, so you can start asking the questions. So maybe I'll just move this away. Yes.
So this is first question I am taking, which is asked many times and this. So what are the cardiac abnormalities are there which can be detected in level 1 scan, sir?
By level 1
first trimester scanning, so like that, sir. 10 weeks.
Okay. Is it level 1? I mean, that is first trimester.
Yes, sir.
Okay. So I am going to say first trimester. The first response to that question is that I am not an expert in first trimester fetal heart evaluation. This is primarily the domain of the fetal medicine people. Okay, but that is fine. But now I'm going to answer that question. First trimester, of course, the 4-chamber abnormalities, I think that would be the most obvious. Most people who get good pictures in first trimester should be able to see whether the 4 chambers are intact and whether both the inflows are patent. I think that is quite possible in first trimester. That is one. So I guess if there is a hyperplast which is already formed in first trimester, you should be able to pick it up. If there is a complex isomerism which is there in the first trimester, you should be able to pick it up. So that's very, very clear. The second, of course, will be the outflow anomalies, which I'm sure it will need color, and especially the 3VT view. I have seen Simon actually showing pictures of these, Simon Mark, and which is so good. He's shown very, very nice pictures of first trimester, outflow anomalies, and particularly that V sign, that is very useful when you put color in the 3VT view. This can obviously help you to see whether there are 2 outflows, whether they are normally related. I am sure that the good ones amongst you can pick up a transposition, and sometimes you can pick up a pulmonary atresia or a common arterial trunk and so on, right? So I think I will use, as far as a pediatric cardiologist is concerned, the first trimester should not be a diagnostic, evaluation. It is good enough if you suspect that there is a heart disease or a complex heart disease. But there are a lot of problems. A first trimester, the specificity of the first trimester evaluation is questionable. And the problem is there is no one to arbitrate you at all. You give a diagnosis and ends up with an obvious choice from the patient, and there is nobody to arbitrate your diagnosis or even confirm whether it is correct. Because how many of you are doing the fetal autopsy to confirm? So I will put a lot of caution towards giving a confirmatory diagnosis during the first trimester. That is number one. Number two is a number of conditions can be actually missed in first trimester. This includes evolving lesions. Many of the outflow anomalies like pulmonic stenosis or aortic stenosis, coarctation of aorta, even for that matter, hypoplastic left heart syndrome. It can evolve as the pregnancy as progresses. Cardiac rhythm problems obviously mostly are missed in first trimester. Cardiac tumors are missed. So I think the first trimester evaluation, in my opinion, should be restricted to pick up the most obvious things and the most complex things. And it should be a multi-system evaluation and not just the heart. I will give more importance to, like, what is the NT? Is there a possibility of an associated genetic problem? Are there major extracardiac anomalies? Is the heart defect a part of a complex multi-system problem? This is what I am more interested than saying that I diagnosed a bicuspid aortic valve in first trimester. Somebody going around town saying that I diagnosed this in first trimester. I can show this picture. I could see a TAPVC in first trimester. No, that's not the kind of an approach which I would prefer. And I'm sure that with more and more better and high resolution machines coming up, most of us will end up picking up a lot of problems in first trimester. But I will use the information which we get in first trimester with great degree of caution, because there are no arbitrators for the first trimester diagnosis.
Okay. And so the next question is how to differentiate between ASD and foramen ovale?
Okay, I think this is a question like, if you have a primum ASD, that is the one which we are expected to diagnose in utero. Because primum ASD is where the septum primum will be missing. It's a part of the AVSD complex. Typically, you lose the offsetting of the valves, and it's actually a part of it's like a type of AVSD, atrioventricular septal defect. Now, diagnosing a primum ASD is important because obviously it's a part of AVSD, which means that associated conditions could be there. So you need to rule out trisomy 21 when you have AV septal defect. So that is why it's important. I don't think you should try to distinguish between a secondum ASD and a foramen ovale. That is really ridiculous to try to do that in the fetus, because most of the time your effort to distinguish that will be wrong. And there is no point, and you are not expected to diagnose an ASD in the fetus, except the primum ASD. Okay, so there is obviously that answer for that would be a very, very clear answer. Please do not try to diagnose the fossa ovalis ASD or a secondum ASD in the fetus. Then there is a third type of ASD called sinus venosus ASD. Those are all going to be a very, very difficult diagnosis. Again, you have ASD. This is a totally correctable problem, and it will be much better if you actually don't go into such details, because all of them have healthy lives once corrected. So I don't think I can distinguish between a fossa ovalis ASD and a foramen ovale in the fetus. I can diagnose a primum ASD. I would definitely want to diagnose a primum ASD because of its associated defects. And the sinus venosus ASD, I don't think most people can even think of diagnosing such entities. It's very, very difficult.
Okay, sir. So the next question is, it's like, can you explain the difference between the mitral atresia and HLHS?
Okay, that is a good question. Now, mitral atresia, look, I think it's very important to understand each term by what it means. Mitral atresia just means that mitral valve is atretic. It is not patent. Okay. Now, downstream, you can have different possibilities. Sometimes you may have a very large VSD with the mitral atresia. There could be, in most of the situations, the mitral atresia is associated with the univentricular type of heart. But then there are different permutations and combinations possible in mitral atresia. The outflow tracts can be highly variable. in mitral atresia. You can have normally related outflows, you can have trans from in mitral atresia, all combinations. When you say hypoplastic left heart syndrome, you are describing a very specific entity. And classical components of the hypoplastic left heart are one, the LV is hypoplastic. Typically, it will be very, very bright, what we call endocardial fibroelastosis. It's because it's a very hyperechoic walls. The LV will be not forming the apex of the heart. The RV will form the apex of the heart. Typically, the ventricular septum is intact in HLHS. So that is about the left ventricle. Most of cases of HLHS have mitral atresia or extremely severely stenosed mitral valve, almost becoming atretic, with the result that the foramen ovale will mandatorily, obligatorily, it will shunt from left to right. And the final component of HLHS is typically aortic atresia. There's no antegrade flow into the aorta, and it's typically a retrograde flow. So when we say hypoplastic left heart syndrome in this entirety, you mean mitral atresia, aortic atresia, and a hypoplastic LV, which is not forming the apex of the heart. This is the entity which I call HLHS. Many of you give names like even sometimes heterotaxy or isomerism with a small LV is termed as HLHS by some people. Those are not entities for me. I am a cardiologist and I go clearly by anatomy and pathology correlates when I say a particular entity. So I hope this is clear.
Thank you, sir. So the next question is that most of the anomalies are being diagnosed at 20 weeks scan. The question is, should we evaluate a little later, like 24 weeks or?
Right. That is a very, very, very relevant question. I think this is a question which is completely diametrically opposite from the first trimester persons. I know that in fetal medicine there is a tremendous interest to diagnose the cardiac anomalies even before the baby is conceived. First trimester is now moving about 8 weeks and 9 weeks, but it is okay. I mean, I'm not going to question that development. However, let us be more realistic here. See, I'm talking to people who are in South Asia, which is India, Bangladesh, Sri Lanka, Maldives, then Nepal and Myanmar, and I mean, in large portions. Yesterday I had a symposium which I was addressing senior pediatricians of the Indian Academy of Pediatrics, and the discussion there was in most places of India, except maybe some centers in urban India and where fetal medicine specialists are there. In largest part of all these countries, there is absolutely no concept of fetal heart evaluation. Nobody does first trimester. Nobody even does NT. Majority of people pregnancies don't get mid-trimester anomaly scans. So with the result, majority of the fetal cardiac anomalies are missed only. First trimester, we forget first trimester. Even second trimester, they are missed. For me, whenever somebody looks at the fetal heart, the fetus at any point of pregnancy, irrespective of which period of gestation, if you pick up an anomaly before the baby is born, it's always helpful. Let me illustrate it with a classical example, which happened this year, real life scenario. A woman was diagnosed to have a heart defect, suspected to heart defect at 38 weeks pregnancy. She was referred to a pediatric cardiologist. At 38 weeks and 4 days, they took 4 days to go to pediatric cardiologists because they were from a very rural part of India. The pediatric cardiologist who was trained by us diagnosed this condition as transposition of great arteries, TGA. This was from another state not from Kerala, from outside Kerala. And this patient was advised delivery in a pediatric cardiac center. The woman came and very, very surprisingly, the screen, and now we live in a very peculiar time and peculiar circumstances add on. So the woman had COVID positivity. The baby was delivered in our center. The baby underwent an arterial switch and baby survived and discharged. And I did not see the family because of obvious restrictions. I saw the baby, but finally after everything was over, we reunited the family and the baby is doing exceptionally well. When was the diagnosis made? 38 weeks and 5 days. Life-saving. If that baby was born in that rural place, the baby would have died. So what are you talking about first trimester diagnosis? Diagnosis at any time in pregnancy is good enough. Same way, if you diagnose a hypoplastic left heart at 38 weeks and 5 days, till you can tell this is a complex problem, family has some time. Yesterday I saw another case, HLHS, which came 3-day-old baby in cardiogenic shock. No diagnosis, no prenatal diagnosis, no postnatal diagnosis. Baby came in shock and we diagnosed hypoplastic left heart in our center. And the baby was so sick and acidotic that there was no option but to go into an ICU. So and now it's a real difficult situation. So if you have a prenatal diagnosis any time before delivery, we can counsel, and so that appropriate decisions can be made regarding managing the baby after birth. The problem is most people who make diagnosis, they don't know what happens to these babies after the babies are born. And I see the full picture because I see these patients after they are born, we treat them. So I know how much difference and impact a diagnosis makes irrespective of this. In our series, about 40% of all fetal CHDs were picked up for the first time in third trimester. We have more than 500 cases diagnosed in the third trimester, and even a third trimester diagnosis can have a very significant impact for the management after birth. So I think your question is very correct. You should continue to evaluate irrespective, and if there is no proper fetal heart evaluation done in early pregnancies, you should try to do it whenever it is possible. Even if somebody was referred for an growth scan at 28, 30 weeks, still if the heart was not seen before, please look at it. I thought this is a very good question. That's why I spend more time in answering it.
Okay, sir. Thank you, sir. The next question is, sir, is the isolated ventricular inversion possible causing TGA type of physiology?
Whoever has asked this question, I will answer that person privately. Okay. You note down this person, and we will and can direct this question to me through my email. Zina, that will be your job, because this is a very complex thing, and if I go into this discussion, then we will have problem. I've been talking for 2 hours now, so I will be continuing to talk for another 1 hour at least to answer this question.
Answer the question. This is a repeated one, which is repeated by many. So to explain TOF and TAP VC little bit, sir, again.
I didn't understand. TOF and
tetralogy of Fallot and TAP VC, sir.
TAPVC.
Yes, sir. TAPVC.
Okay, I think these are two entirely different diagnoses. Tetralogy of Fallot is obviously a situation where you have a VSD due to malalignment of the ventricular septum and the aortic valve. That's a loss of septo-aortic discontinuity, aortic override, and pulmonary stenosis. That is tetralogy. So obviously that's a completely different entity. Total anomalous pulmonary vein drainage is a totally different diagnosis. Normally the pulmonary veins drain to the left atrium. Here they drain to the right side of the heart. They can drain to the SVC or inside the right atrium or to the IVC. So we call it supracardiac if it goes to SVC, infracardiac if it goes to IVC, and cardiac type of TAPVC goes into the right atrium. So completely different entities, and so obviously the implications are different. The good thing is, common thing for both is that both are conditions which can be completely corrected after birth by surgery, and the long-term outcomes are excellent for both, especially for TAPVC. The long-term outcomes are even more really supremely good. So that's the only commonality, but regarding the imaging, they are two completely different entities.
Answer the question is one on the machine settings. What should be the PRF should be there on the machine to detect VSD, sir?
Okay, I will say that for pulmonary veins, we should have a pretty low PRF. I usually go to a PRF about 1.3 meters per second. That's very low, much more low than what you would put for outflows. And if you have machine has the capability of HD flow, etc., then obviously those things are very helpful. That is one. The second thing is very important. When you put color, don't put color over the entire baby. We are not playing wholly with the fetus, right? So we put color only at the point of interest. So if you want to see the pulmonary veins, you put the color box only at that area of interest. So you are obviously your frame rates. Anyway, when you put color, your frame rates are going to come down. That's universal because color relies on Doppler. So you put a small color box and reduce PRF to about 1.3. That's the time when you get the pulmonary veins very clear.
Okay. And the next question is, sir, how to differentiate persistent truncus from double outlet ventricular pathology sonographically?
Okay, I think these are completely different entities altogether. And the common arterial trunk is a situation where you have only one outlet. Double outlet, obviously you are saying there are two outlets, right? So, if you see two outlets, it cannot be common arterial trunk. Understand? So, obviously it's a completely different, it's not even a differential diagnosis, DORV. What is the differential diagnosis of a common arterial trunk is what I showed. Two conditions which can cause a single outlet are VSD with pulmonary atresia and common arterial trunk. Now, some people say TOF pulmonary atresia. Sometimes the aorta may be completely coming from the RV. So people say DORV pulmonary atresia, but those are all complex terms. Basically, there is a VSD and aortic override, and there is only one outflow, that is aorta, and the other outflow is getting blood reversed through the ductus. So I think the differential diagnosis of a common arterial trunk is actually TOF pulmonary atresia. Most of you got that wrong because I think most of them have not internalized the concept of these two entities. DORV, obviously you have two outflow tracts, both coming from the right ventricle. And of course, it's like there are different types of DORV. Again, it's like very difficult to discuss those in detail here because it will take a lot of time. But the most common type of DORVs are two types. One is a TOF type with normally related great arteries, and second is the TGA type, which is the transposed outflows. So obviously, this common arterial trunk and DORV are not really seriously DDs. Okay. Maybe 5 more minutes, Zeenath, and
Yes,
after
sir.
that we can probably use email to answer.
Sure, sir. So the question is that how to detect aortic interruptions.
That is a very good question. I think that is something which is very important. I did show some of these pictures of aortic interruption, and the most important clue for aortic interruption is that when we look at the three vessel view, you will find that normally in the three vessel view, the aorta and the PA both will go up to the spine and join. In the aortic interruption, typically there will be a gap between the aorta where the ascending and the mid thoracic aorta and the trachea. So that's a gap. Second is that when you put color, the proximal aorta may have a forward flow, blue flow, but the distal aorta typically will have a retrograde flow in the 3VT view. So that is two. And of course, when you go for the sagittal view of the aortic arch, you will find that the ascending aorta is very small, and often there will be lack of continuity between the ascending and the descending aorta. So that is the characteristic sign. And the descending aorta will be completely supplied by the ductus arteriosus. So the ductus will continue as a descending aorta, while the ascending aorta goes to transverse arch and will get completely stopped there. We have actually published the use of 3D, 4D stick in the diagnosis of aortic arch interruption. It is there in circulation 2018. If you put my name and this paper, 3D stick in aortic interruption, it will come up in circulation cardiovascular imaging. We have nicely described all the features in that paper. Maybe you can read that, but these are the clues.
Fine, sir. So thank you, sir. Now we can wind up for the today's session, and so I will share the questions to you. So
yes. So what you can do is you can put the questions. I will try to answer as much as possible, not today or tomorrow for sure. And over the next week, I will put down the answers. Sometimes if the questions are repeated, I will try to put common answers and then you can communicate. The person with ventricular inversion, obviously, you can probably give my email and they can directly ask me that question because it's a pretty difficult question. Maybe I can just say there is this entity called ventricular inversion, just to sort of end with that curiosity. See, when you say ventricular inversion, normally let us look at how the heart segments are connected. The atria connect to ventricles and ventricles connect to outflows. So when you say atrioventricular concordance, right atrium goes to right ventricle, left atrium goes to left ventricle. Then outflow LV to aorta and RV to PA. Okay. In TGA, you have atrioventricular concordance, that is RA to RV and LA to LV, but ventriculo-arterial discordance, that is LV to PA and RV to aorta. In ventricular inversion, what happens is you only have atrioventricular discordance, but the outflows are normal. That is, RA goes to LV and LA goes to RV. RV gives rise to PA and LV gives rise to aorta. It is like a TGA, but this is how you distinguish. It's obviously complex for many people and it needs more discussions. Maybe we can have a direct discussion with the concerned questioner, the person who asked the question.
Yeah.
Okay, so shall we wind up?
Sure, sir. Sure.
Okay.
Thank you very much, sir, for this wonderful session. And there are a lot of questions there, and still it's coming. So, and thanking all the viewers also for your patience listening. And I hope you have enjoyed this webinar. And I would next 16th Jan. So we'll have a next webinar from Dr. Balu Vaidyanathan for this fetal echo series part 2. So I would like the details of this program, the webinar we will share soon. Thank you for joining us. Thank you very much. Thank you.
Thank you very much.
Sir.
Bye and good night and happy weekend to everyone.